so much. We're going to move now to the final panel on clinical management and public health interventions. I'd like to invite the two speakers, the two panelists to come forward. Dr. Albert Coe, who is Chair of Epidemiology and Microbial Diseases, Yale University School of Public Health, who will go second, and Dr. Laura Elizabeth Riley, Director of Obstetrics and Gynecology, Infectious Disease, Massachusetts General Hospital in Boston.
Thank you very much. I'm going to be probably the quickest person you've heard all morning. This is all about perspective for me, and so I'm just going to tell you a little bit about what I do every day, which is I'm a high-risk obstetrician, and so what I've been dealing with is seeing women come in who have been exposed, and now they want to know, what should we do? So that's really my perspective. So you've seen this before. This is the New England Journal article that just recently came out, and I'm just going to describe just quickly a little bit about that patient. This is a woman who had been in Brazil, and at 13 weeks gestation, she noted symptoms consistent with Zika virus. And she actually went back to her home and had had ultrasounds at 14 weeks and 20 weeks gestation, which really only showed a mild decrease in growth of the baby, but no malformations at that point. And then when she returned home, she had another ultrasound now at 29 weeks gestation, and on that ultrasound, this is what they found. You can see I don't see the pointer in front of me exactly, but there are intracranial calcifications on one panel, and then on the other panel this is a cross-section of the placenta, and there are intracranial calcifications. And you can see on the postmortem specimen, these are the areas where there are the calcifications as well. And then this is microscopic analysis of the brain tissue, which showed that there was virus throughout, and you saw these panels earlier from Dr. Diamond, I believe. And so when we start to think about, how are we going to counsel these women who have been exposed, and then they, come back to the U.S. and we need to decide what to do with them, this is the guidance that came out recently, the most recent guidance that came out from the CDC about how to handle these patients. So, how we put this together, we take the guidance from the CDC, and how we put this together is also using, and I apologize, I jumped ahead. This is from the MMWR that was published from a few of the cases that were in Brazil, and a real dive down look at those pregnancies. And things that are important to us certainly is at what point during pregnancy did the infection occur? And from this small group of studies, small group of patients, most of the infection occurred in the first trimester. There was some in the second trimester, and then a full 26%, there was no known time of the exposure. So that's obviously an important point for us. The second piece of information I think that you'll see becomes important is that obviously what we were looking for and what we've been focusing on is microcephaly, but I just point to you at the bottom, you see that there are other issues, including, other than calcifications, ventricular enlargement, as well as lissencephaly, which was something that was mentioned in the last speaker's presentation. So there's a number of other potential neurologic abnormalities to consider. So now we're going to those guidelines which I mentioned before, and I put a big arrow here because the number one first stop for someone who has traveled and been exposed, for a pregnant woman who's traveled and been exposed, the first step is to do a test for Zika virus infection. That test is the IgM test, and so we're putting a lot of stock into this test, a test that we don't have a lot of information about, and I'll bring that up again. And then another piece of the algorithm, this is for women who live in an area with ongoing infection. In addition to the the information that we're going to get from the Zika test, there's also, you'll see these 3 arrows are pointing to the reliance upon ultrasound. And so we are, putting a lot of energy into doing these ultrasounds, and then you'll see that some of the ultrasounds are even serial fetal scans. And so this brings up a whole set of other questions, including, at what point are you going to see those abnormalities of the microcephaly, of the lissencephaly, of the intracranial calcifications? How often do those ultrasounds need to be repeated? What information are you going to gain over time from those? So again, these are big areas where we really don't have any information. And again, it's all about perspective, as Dr. Laurie said, and so as my perspective as an OB provider, you can imagine I'm sitting in a very small room with a couple that wants answers, and so what I'm doing is I'm taking the CDC guidance, and I'm taking my own knowledge of CMV and rubella, and I'm trying to put it all together about Zika virus, of which I know very little. So we don't know what the infection rate is, and more importantly, the incidence of maternal fetal transmission by trimester is particularly important as well. And what are the factors that influence that transmission? Is it the severity of maternal infection? Is it the maternal immune response? We don't know. We have information that we can glean from other infections, as the last speaker had mentioned. Also, the causal relationship between Zika virus and other adverse pregnancy outcomes, I think we have probably pretty well established the association with microcephaly, but as I mentioned to you, there may be other neurologic abnormalities that we should be aware of and looking for that we don't yet know about. And then again, the full spectrum of phenotypes in affected fetuses, again, is not completely known, but I know our next speaker may mention some of those. In addition, the immune response to Zika virus infection, I think that's very clearly a priority. The peak and duration of that response, obviously the cross-reactivity of Zika IgM with other related flaviviruses needs to be considered. So again, the reason that I put a focus on that is because that's the second step in our algorithm, and not having the answers to these makes it very difficult to counsel women. And then obviously the performance of serologic testing for asymptomatic patients, the IgM, how well does that work? And once we get a negative result back, is it really negative? And at what point can you tell a woman that it's negative, you're good to go? And then finishing up, and the other questions that we have, I didn't point them out on the algorithms, but for women who then are found to have IgM positive or an ultrasound abnormality, the next step in the algorithm is to do an amniocentesis, or is to consider doing an amniocentesis for Zika PCR. And it is not known at this time what the sensitivity or the specificity of the Zika PCR is in amniotic fluid. And then the next question comes up as well, which is what's the optimal timing for amniocentesis based on our knowledge of fetal infection and the fetal response to infection. So that's just a few of the questions that a high-risk obstetrician has, and many general OBGYNs as well, as we're trying to, give women reasonable counseling. Thank you.